Hello, everybody. Again, I think it's probably time to start tonight's COVID-19 question time webinar. Thank you again to everybody who's joined up. Thank you for sending all your questions in. And it's a big hello. Hello, Jane. First of all, then, I'd like to just do a few of the sort of admin pieces, and then we're going to introduce you to our panel. So, Kelly, if you could go on to the next slide, please. And of course, what I should have said is that this webinar is being hosted by us here at Kidney Care UK, but we're doing this in partnership with our partners, and you can see them all along there: UK Kidney Association, Kidney Research UK, the National Kidney Foundation, the Polycystic Kidney Disease Charity, and Kidney Wales. And let's just start the conversation. So if you're tweeting about this, we're going to be using COVID question time as the hashtag. And during the webinar, if you looked at the bottom of the screen there, you'll be able to see a Q&A and a chat there. If at all possible, could you put your questions in the Q&A? Because that's the place where we can post them, we can answer them live, if possible, by the panel, or we'll keep some of those and answer them as we go along. You can upvote any questions by clicking the thumbs up next to the question. But it's a reminder to everyone that for your personal medical questions, please talk to your own kidney team. We can't answer those questions here. Now, the chat box is more to post any technical issues. I can't hear, you've gone funny, Fiona, I can't hear you, that kind of thing. And our colleague Kelly will be on hand to help you with that. So if you didn't see it at the beginning, the webinar is being recorded and we'll make it available on YouTube, and a summary report of all of this will be published on the website. Okay then, so what I'd like us to do then is introduce you to the people on our panel tonight. If we can go to the next point. So we've got four fantastic doctors with us this evening. And what I should say, I suppose, is at this stage, and I'm sure you'll all agree with me, that I'd like to give a huge thank you. We'd like to give a huge thank you to all of our medical teams, the multidisciplinary team, our nurses, our doctors, everybody, dietitians, pharmacists, and so forth. All of you have played such a huge part in supporting us over time, but also particularly over the last few months when the Omicron variant came out and we didn't know what was going to happen. We'll be able to report on some of that as we go through. So if I could just to introduce you, first of all, to Dr. Andrew Frankel. Andrew, could you just introduce yourself, please?
Good evening, Fiona. Good evening, everyone. I'm Andrew Frankel, and I'm a kidney doctor working at Imperial College in London.
Thank you, Andrew. That's very, very good. Thank you. And then Becky Suckling. Dr. Suckling.
Hello. Hi, everyone. I'm Becky Suckling. I'm a nephrologist at Epsom St Helier, and I will be typing in the questions and answers. So, and you won't hear from me, but you'll hear from me in type.
You might hear from Becky as well. Sometimes she comes on as well to let us know or update us on different things as we go through. We're very interactive like that. Okay, so next I'd like to invite Professor Liz Lightstone, who's also speaking with us tonight. Liz, please could you introduce yourself?
Hi, I'm Liz Lightstone. I'm one of the profs of renal medicine. I'm also at Imperial College and the Hammersmith.
Indeed. Thank you, Liz. And last but not least, Professor Richard Haynes. Richard, there you are.
Hi there, I'm Richard Haynes. I'm a kidney doctor based in Oxford.
Thanks, Richard. And I should say that all of these people are extremely eminent and extremely well qualified to talk to you about the subjects tonight. And they've been involved with either different studies, different pieces of work, right the way through the pandemic, and of course, for years before that as well. So I should introduce myself. I'm Fiona Loud. I'm Policy Director for Kidney Care UK. I'm also a recipient of a kidney transplant 15 years ago at Christmas, and I spent 5 years on dialysis. And alongside me, I've got the Kidney Care UK team. They probably won't come on the camera, but we've got a policy officer, senior policy officer, Sam Sharp. Sharon Woodward looks after all our comms and media, much of it, and Kelly Newell, who looks after our IT. So I'm very grateful to that team as well for helping us with the webinar tonight. I can see there's already 10 questions in the Q&A. So I would just hold on because you sent through an awful lot of questions to us as well. And what we've done is, Kelly, if you could go on to the next slide, please. So what we've done is all the questions that we've received, we've split them into kind of a number of areas so that we can try to address them as we go through. So the first one will be looking at the current level of risk from COVID-19 for people with kidney disease. Where are we now? You know, we've had Omicron, we've had Delta. What's going on at the moment? The next one will be, what do we know about the vaccines? How effective are they? What about that third dose? What about that fourth dose? And then we'll be looking at, which I know will be of great interest to people, what are these new treatments for COVID for people with kidney disease, people like us? So I would also urge you to kind of listen to what people are saying before you put all your questions on the side as well, because it may be that your question has come up in these pages of questions that I'll be referring to as we go through this evening. So I think then it is probably time, Kelly, if we could just go to the next slide, please. And what I should also say to everybody is, if you're listening on your phone, it really doesn't matter because we've only got another 3 or 4 slides that most of them will come at the end. It's just for the people who are watching on the screen to see what's going on. So all the slides have said is people's names and they're just summarizing the questions. So what we're going to do now is if I could ask everybody else to go off camera, but Andrew to stay on camera. Kelly, if you could switch the slides off so we can see Andrew and myself talking, that would be great. There you are. Great. So Andrew, as is now become traditional with some of these things, thank you very much again for joining us this evening.
Pleasure.
What would be really helpful, just to sort of answer some of the more general questions that we've been getting through, is if you could give us a bit of an introduction about the current picture on the impact of COVID. What do we know about Omicron? What about its risk to people with kidney disease, people with transplants? And perhaps if we could kick off with that, that would be great.
Certainly. I've sort of lost count, Fiona, of the number of webinars we've done, but it's important to appreciate this has been a crisis that's been running now for 2 years, and it's had a profound effect on all of us, whether we're healthcare workers, but of course, most importantly, for people with kidney disease. I don't think we can say that we've emerged at the other end of this pandemic, but we can be much more optimistic that there is true light at the end of this tunnel. And most importantly, and I think this will be demonstrated during the webinar, we've learned a significant amount that is going to be incredibly useful to us over not just the immediate future, but probably in the coming years. I think that we can say that we've moved from a really devastating respiratory infection for people with advanced kidney disease, on immunosuppression for kidney disease or with a transplant, to a situation where we've had a successful vaccine rollout, and as I think we will describe and demonstrate in the webinar, a variety of treatments for this virus. We've seen a change in the virus itself with the appearance of different variants, each of which have generally followed the expected evolution of a virus, which is as the virus evolves, it tends to become more infective, but yet less damaging. As a result of the medical advances that are being made and the change in the virus, while we still have an ongoing epidemic at the moment of the Omicron variant, the number of people who are becoming unwell with this virus is diminishing. And indeed, fully vaccinated people with kidney disease may get reinfected, but their chances of ending up in hospital or even worse on an ITU is very much diminished compared to where we were last summer or last year. And I think we are going to see ourselves moving from a situation where we're managing a virus that is spreading rapidly through the community to one that is likely to become part of the seasonal infections that we all have to live with and manage. The difference now is that we have much better weapons at our disposal to manage this. So while I really understand everyone's ongoing anxieties, there's a huge amount to be reassured about. And I hope that we'll be able to cover these and some of this during this webinar today, Fiona.
Thank you, Andrew. That's really encouraging. I have to say that's the kind of thing that we've been hearing as well. I know people were worried in December, but the evidence has borne out something different. Would you agree with that? Yeah. So is there anything that you can say particularly about the current rates of hospitalization? I mean, you've sort of touched on that anyway, but because we had a particular question about current rates of hospitalization, death, transplant loss for people at this stage of the pandemic, as you've rightly said, 2 years ago, it was such a different place. And we've probably had, what, 8 or 9 of these COVID-19 webinars as we've gone through, kind of marking each stage. And it is, I think, encouraging that we are at this probably a different stage now. But I wonder if you could just comment a little bit on that.
Yes, I mean, when you look at the data, of course, we've seen huge numbers of people with kidney disease, as you would expect, because there's huge numbers of people in the community acquiring the Omicron variant through December and January. So there's been a large number of people who've been infected. There's definitely been people being reinfected, i.e. people who were infected in the first wave or the second wave are now getting it again. But what we are seeing is that those people, when they get this, are getting much, much milder disease. So for us at the Hammersmith and the Imperial in Northwest London, while we had a lot of people on dialysis who we had to isolate or cohort because they had acquired Omicron, the numbers of those people who required admission was significantly less, very much less than in the last waves. And the number of people who actually became very unwell was equally down. And I would put it to you that if you look at the figures, fully vaccinated, and we're going to talk about what that means today, people who acquired Omicron were generally getting mild disease and were not getting the kind of disease taking them to ITU and unfortunately resulting in death that we were seeing in the previous waves. Of course, there are rare exceptions, and there are, of course, people who are not fully vaccinated. But this is where I want people to be reassured that we are seeing a significant change that is based on the change in the virus, the vaccination program, and also the fact that we now have treatments that we can use to help reduce people who acquire this disease from coming to harm.
Thank you. And I've just got one further sort of question in this section, as I meant, it's just to clarify a little bit more about that. So, and you may not know the answer yet, but certainly we've heard from lots of people over this last couple of months who are getting Omicron, exactly as you said, but seem to be in the main doing fine with it. Obviously, it's not great, but you know, reporting back again that they're okay after a couple of weeks, sort of thing. But if I get COVID again, this is the question. So, am I just as likely to get a mild disease, or is there a chance of an increase in severity? Do we have any data on that?
Well, we have data if you are on, particularly in relation to getting COVID again in the context of full vaccination. I can be really fairly reassured, not just fairly, I can be reassuring that if you've had COVID before and you've had full vaccination and you get Omicron, the likelihood is that you will have a very mild and might even be a completely asymptomatic, which means you don't even know you've got it if we hadn't have tested you, disease. If, however, you've not been vaccinated, then the expression of the disease will be stronger. But again, Omicron is milder. And as I've described, we now have newer treatments to manage it.
Thank you, Andrew. That's great. Thank you very much for the kind of the opening. And I can see lots more questions still coming up, but hopefully we're starting to get to answer some of those questions as well. I wonder if I could invite Liz to come on the screen now, if that's okay, if you're there. I know you are. And Andrew to, and Kelly perhaps to focus on this. There you are with your, with the lovely background there that we talked about earlier. So Liz, I think, and just for everybody listening, we're going to move on now, just to talk a little bit more about what the latest research is telling us on how effective the vaccines are. And I know Andrew has just kind of queued you up for that quite nicely, particularly after 4 doses and anything we've got about that. So I think my main question to you really is sort of, anything more you've got on the latest research on how effective the vaccines are, especially after 4 doses. And then we'll go into a couple of questions about, are 4 doses safe for me and my kidney? Is it okay for me to have additional doses of the COVID-19 vaccination?
So I think there's good news out there. And actually, I'd start with 3 doses before getting on to 4 doses. So for an awful lot of people are not immunosuppressed, but have kidney disease. And 3 doses of vaccine is proving very effective. And we saw that in our hemodialysis populations, just as Andrew said, that there were huge numbers infected in a very short space of time over Christmas and New Year. But actually, at Imperial, we had almost no admissions. I mean, I think we had 4 or 5 people out of over 200 infected, which is so different from a year or so ago. And we've got good data from the labs looking at immune responses to show that the 3rd dose is really necessary. 2 doses does not cut it when it comes to Omicron, even if you had previous infection. So I can't stress the importance of getting your 3rd dose. And then if you're someone who's counted as in the clinically extremely vulnerable group, and that's mostly the immunosuppressed patients, then the 4th dose is recommended. And the reason for that is we know there's a proportion of patients who don't respond well or not at all to the 3 doses. And there are data coming out now, particularly from France and also our own local data, that each time you vaccinate, you get more people converting. And if you've got antibodies to start with, and mostly what we're measuring is just the antibody response, which is a marker of how well you're responding to the vaccine, but doesn't tell us anything about what are called T cells, which is a different part of your immune response. But with the people who've got, say, a weakish response with the 3rd dose are likely to have a very good response with the 4th dose. And we've seen that, and that's also reported from France now, and gradually more studies are coming out showing that. So the 4th dose adds. There are a small group of people, and particularly those who haven't responded to 3 doses may not respond to a 4th dose, but they won't come to any harm from a 4th dose. So it may boost you, it may not. And then there's a whole different discussion about that. But we would certainly recommend the 4th dose. And that's 3 months after your 3rd dose, which was your 3rd primary dose. And I appreciate all the confusion that's been out there, but we do recommend it. We do think it's safe. There is nothing to suggest that it's bad for your kidneys. Vaccination does stimulate the immune system, and very rarely some things can be triggered off, but COVID itself is a very, very good stimulator of the immune system. And we're not seeing harm from these vaccines, and we are seeing definite benefit.
Great, thank you very much for that reassurance. Now I've got a couple of other questions that you've seen about the antibodies as well. So the first one is kind of related to what you've just said there, but how long do antibodies last? And that's a very open-ended question. But
so it is a difficult question to ask. They definitely wane. So, immediately after you've been boosted, they can be really impressively high, and they wane over the next few months. But the whole point about vaccination, and that's sort of what we don't really know yet, is that they're there, they're ready and waiting, and then your B cells, which produce these antibodies, are sitting behind there. So when they see the virus, they can boost. And you see that in patients who come in. They come in with very low levels of antibody often, and then during the course of their infection, they'll get very high levels. So the fact that they drop off over time does not mean you're not protected. I think the greater worry is that you never produce them when you're boosted, but that they drop off over time. But also it's not unusual. I mean, many of you are on dialysis will have had a course of hepatitis B vaccinations, and that course requires at least 3 doses, in some people more. So it isn't uncommon to need 3 doses. It's less common to need 4, but there's no suggestion at the moment that we're going to say you need a 5th in a couple of months, because this seems to be pretty effective against Omicron at the moment. I think you are likely to need 1 in a year's time, but that's a different matter. That's making it more like flu.
Lovely. Okay, thanks very much for that. So without kind of going into sort of some of the details that we've sent about people's tests and things, I mean, we all know that people have gone out and taken their own and paid for their own antibody tests. And we also know that quite a lot of people have already signed up to the Melody trial that's around at the moment. And I know you're one of the investigators on that. So it's a nice cue for me to ask that question. So somebody here, and I know I've seen other people speak about this as well, they're part of that study, and they have no antibodies after 4 jabs. And I know later on we'll be talking about preventative, other treatments, and that would be that. But I wonder if there's anything you can comment on here about perhaps kind of extending a little bit more about what you were saying about other parts of our immune system that could help to reassure.
So all we're measuring, so the MELODY study, for those who don't know, is a bit like what you might have heard of in the general press, which was done in the general population, the REACT-2 study. We send out, looks just like the lateral flows you do for COVID, but it's measuring antibodies. And we're asking people with transplants to sign up to the study, and you get sent a little kit and you do a pinprick after your 3rd or 4th dose, and we see if you have antibodies. And a small proportion are not going to have antibodies, but that doesn't mean you have no reaction. That's detecting a higher level than if we did a lab-based blood test. So the fact that you haven't got it on that test doesn't mean you have none. And also there are other bits of your immune system which respond to vaccine, which we would not be detecting, particularly T-cell responses. So it doesn't mean you're entirely unprotected. And we sort of know that because we've got a lot of patients that we know have low antibody or no antibody levels who've had Omicron and have been all right. So I don't want the message to be doom and gloom. I think there is a level of caution that still needs to be asked. And these are questions we're going to ask in MELODY. We're going to look at all the people who respond, and we're going to compare the infection rates because it's linked to NHS England results. We'll look at all the infection rates and hospitalizations in those that do and don't have antibodies. So we'll get a much better handle on the proportion of people who get unwell or at least get infected when they don't ostensibly have antibodies. We'll come back to what the other protective measures are, but there are definitely things that can be done now to protect you if you get COVID. And I think there will be treatments in hand for those who are antibody negative even before you get COVID. That's our hope.
Great, thank you. And for anybody who wants to sign up for the MELODY study, I think you just Google MELODY transplant
MELODY
patients.
MELODY study, and you'll get there, and you'll get to the link for the transplant patients.
And it's also on everybody's websites, all the kidney charities' websites, I'm pretty sure as well. Okay, so finally for this section, so should everybody have antibody tests now?
Oh, well, that's contentious.
Yes.
So because nobody has worked out what exactly the level is of antibodies, and it varies between tests as to what appears to be protective, the proper test is something called measuring your neutralizing antibodies, which actually directly squash the virus, but that's not a practical test. So the test we do is for something called anti-S antibodies, anti-spike protein antibodies, and there are different tests, Roche, Abbott, whatever, and they've all got different thresholds for what they say are positive. And it's still a little early to say exactly what the right level is. But if you have no antibodies, you probably don't have neutralizing antibodies. And certainly at Imperial, we test people all the time, and we are of the belief that everyone should have access. You shouldn't be going and buying it privately. And there's quite a push going on now. And I think there will be a change in the not too distant future from the government, that certainly people who are vulnerable should have access to antibody testing. And of course, it's been rolled out in all the trusts now. It wasn't generally available, but it is available because the trusts have had to do it for these treatments that we give. So the tests are set up. And personally, I think everyone who is on the clinically extremely vulnerable list should have access to their antibody levels. So, you know, not least if they get ill, that they need these treatments rapidly.
Thank you. And just to say that those any antibody tests will be post-vaccine anyway, but they'll be post-vaccination, not beforehand. There's not much point checking beforehand because you won't have had the vaccination there as well. Thank you very much, Liz. We'll definitely be back to you quite shortly. And Richard, I wonder if you could come on to the screen now as well to continue this this discussion. So just for people to be aware, so Professor Richard Haynes, there you are, from Oxford. And so we've had a kind of a range of questions now about the, it's a bit more about the rollout of those 3rd and 4th doses. And we've had some questions there. So a couple of things I'd like to comment on, first of all, which is how to get the 4th dose. So people may not be aware, but it was up in our guidance last week, and the Department of Health and Social Care was just tweeting about it over the weekend. You can now book your 4th dose online. So while the guidance has always been wait to be invited by your professional, healthcare professional, you can now book it for yourself online, but you will have to bring with you a letter from your basically, well, from your healthcare professional explaining that you are severely immunosuppressed, and that would be somebody who's on a transplant like me, somebody who's on a range of immunosuppressive drugs, or somebody who is still on those drugs even if you're on dialysis. So that's something new to add into this. And I know we've heard from quite a lot of people they've had trouble getting the 4th dose, but hopefully that will make that a little bit easier, because it's not been incredibly easy to be able to get that. And I know some people have been anxious about getting it. So that's a small step, but a very welcome one. Richard, can I just kind of bring you into this conversation now as well? We've talked about the 4th dose anyway. And thank you. My colleague Sam has just put on the Q&A there that's how to book your 4th dose if you weren't aware of that, and you're on the webinar tonight. So first of all, Richard, is it compulsory to get a 4th dose? That's a question that's come through of the COVID-19 vaccine.
No, I wouldn't. I don't think any of us could go as far as to say that it's compulsory. Obviously, we've all heard discussions about what might happen for care workers and healthcare workers about the rules for them. But I think for the majority of people, it's not compulsory. It would become highly recommended, I think, from everybody on this call, but we can't compel you.
Thank you. And somehow I knew you'd say that, but as the question has been asked, it's good for us to discuss these things. So what do you think about people on dialysis getting a 4th dose? What are your thoughts there?
Well, the guidance at the moment, as a group, hemodialysis patients are not included in the groups of patients that should have a 4th dose, unless you fulfill some of the other criteria, such as, there are dialysis patients who take immunosuppressive treatments for one reason or another. So they would qualify, but not because they're a dialysis patient, but because they're taking that treatment. But for the majority of dialysis patients, 4th doses aren't recommended. As Liz and Andrew have both said, we've got pretty good evidence they respond well to 3 doses. I think this is something probably that the JCVI, which is the government committee, the independent committee, actually I should say, which recommends vaccination to the government. It's probably something they're keeping a close eye on at the moment, but for now, they haven't recommended that all dialysis patients have a 4th dose. That being said, when I say 4th dose, what I really mean is a 4th dose shortly after your 3rd. It's very likely that we're all going to get offered further doses of the vaccine at some point in the future, possibly as part of our annual vaccination scheme. So they almost certainly dialysis patients will be offered a 4th dose, but maybe not as quickly as the transplant patient and other severely immunocompromised patients have been offered them.
Okay, thank you. And does that also apply to people who are on home dialysis as well? I'm guessing it does, but
yes, I think it would be the same advice to them, and home dialysis of whichever modality. Yeah.
Yes, yeah, any home therapies. Just for the sake of clarity, can we just run back through the guidance about this, because it has been quite confusing, and people will have seen that there've been a kind of a number of questions on your 3rd and your 4th dose. So should we just run back through those for the sake of clarity? So a 3rd dose for people who are immunosuppressed is referred to as your 3rd primary dose. Is that right?
That is correct, yes. So originally these vaccines were developed requiring 2 doses. So what's called your primary course was going to be a 2-dose course. But then it was recognized that some patients didn't respond as well. So they then had a 3rd dose added to their primary course. So for severely immunocompromised patients, the primary course is 3 doses.
Right, and that was where the confusion arose, because I know some people got those mixed up, and the communications from government mixed up the 3rd primary dose and the booster dose that the rest of the population were having at the same time. And I know that's changed now, and you can, as we said earlier, you can book your 4th, but you can also book your booster dose online as well. But again, one of the things is you'd still need to bring a letter with you. That's right, isn't it, to show that you need that dose?
Yes, but hopefully your kidney doctor will be copying you in on any letters they write to you or your GP. So I think just taking that along should suffice, as long as it says somewhere on it that what treatments you're on or your history. But I think that would be fairly standard on any such letter.
Great. And most of the people hopefully here will now have got past that particular dose, but I know not everybody has, so that's why it's worth mentioning. And then just to confirm the timing then, for those who are immunosuppressed by the drugs that they're on, particularly people with transplants, for example, that is then recommended. I think it's 90, how many days is it later? It's 3 months, isn't it?
Yeah, 12 weeks. I think it's officially 12 weeks.
Yes.
But yeah, about 3 months later. So after you've had your once you've finished your primary course of 3 jabs, then 12 weeks later, you can have your 4th dose, as long as you take that letter. And as you say, you can now book that online or get it or go to a walk-in centre. But if you go to a walk-in centre, you'll probably still need to take that letter with you.
Right, and the vaccines you'll be getting are Pfizer or Moderna, is that right?
Yes, it's, I think there's very, very few other vaccines currently being offered in the UK. So it will be, yes, one of those 2 that you're likely to be offered. And it doesn't matter which ones you had earlier on. There is actually some evidence to suggest that having a mix could be good, but having a mix is certainly not bad.
Right. Okay, thank you. And if by some reason, some chance you need AstraZeneca because you've been recommended to have that, that would be something to organise and to speak to your centre about in advance before you went in, I'm presuming.
Yeah. Yeah.
Right. Okay, thank you. I just thought I know we've said it before, but I think it's probably worth saying because of the different timeframes and things that have been involved. Okay, that's probably it for that. The further question was, will people with chronic kidney disease stage 3 or stage 4 get a 4th dose? And I think you've probably already answered that, but that would be, do you want to comment on that? Just because that would be later on, wouldn't it?
It'll be later. It'll be the same as for the hemodialysis patients. So unless you're on some sort of treatment which qualifies you, there won't be a rush to give you a 4th dose just yet, but you're likely to receive a 4th jab at some point.
Okay, thanks. And then what's the long-term plan? I mean, Liz kind of suggested it earlier about where we might go here, but probably an annual, that's what I've heard speak of, with the most likely to be kind of an annual COVID jab for people like us, or for the
I would expect. I mean, there is no formal guidance on this, yes, so we're slightly guessing, but I think, as Andrew said, COVID is, or the virus that causes it, is going to be part of our environment now. And just as we have an annual jab for flu, I think it's quite likely that we will go and have an annual jab for COVID, quite possibly at the same time. It's worth saying that the vaccines are being updated, if you like. So Pfizer have recently started trials of their vaccine specifically for Omicron. So just like the flu jab gets updated every year, when they try and predict what the circulating variant is going to be like, it's probably going to be the same with the COVID vaccinations, that they will gradually change over time to try and keep up with the virus.
Okay, well that's really interesting. Thanks, Richard. And I have got one more for you actually in this section, which is on a very similar but not quite the same topic. So what's the current evidence for how COVID is affecting children with kidney disease? And we've heard from not many, but a few people who just wanted to know that they may be parents with young children who have transplants. And is there anything that you were able to share on that one?
Yeah, so to be clear, I'm not a paediatric kidney doctor. I generally work with adults, but I'm fortunate to know some paediatricians. So when this question came in, I asked them for their advice on what to say, and what they said is that children are very, very low risk of getting severely unwell with COVID. The risk with COVID is strongly related to age, such that the older you are, the higher your risk. But the consequence of that is that the younger you are, the lower your risk. So most children are at very, very low risk of getting severely unwell with COVID pneumonia. Children who've had transplants or are immunosuppressed will be at slightly higher risk than the other people of their age group, but that still leaves them at very low risk. So I think in general, we can be reassuring that their risk of coming to significant harm from COVID, even if they're on immunosuppression, is very low.
Okay. Again, I know that you're not, as you've rightly said, you're not a paediatrician, but just a comment on that. So I think there's 2 doses that have been recommended for children in that group, but some of them may get a 3rd dose as well. Is there anything you can add to that, because there's a couple of questions that come up about people with children with those diseases.
I think in terms of vaccination of children, things are moving all the time at the moment. So originally JCVI recommended a single dose for children between the ages of 12 and 16. That has subsequently changed, and now they're giving second doses to that group. And they have just introduced, or what is about to be rolled out, is a single dose regime for children who are, if you like, at risk, so including children with transplants between the ages of 5 and 11. And I think probably you just need to essentially watch this space, because although that's just recommended as a single dose for now, that may change. I think JCVI are being cautious before they recommend vaccination widely in children, and they're watching to see what happens elsewhere in the world where this is being done before the practice gets adopted in the UK.
Thank you. So as we say, watch this space for younger children, and there's things in place there for slightly older children at the moment as well. So thank you very much, Richard. I think it's now time for us to go back to Andrew, and if Andrew could come onto the screen, there you are. So before we move on to, I can see I've just had a quick look in the many questions there, and there's a lot of questions about those treatments and employment and things, and we will be coming on to some of those, and I know Becky is answering them very rapidly as we go through as well. So just for this session, people still might get COVID, of course, we know it's still around. What should people do? We've talked about vaccination, we're going to talk about those new treatments shortly, but generally speaking, what should people do if they get COVID at the moment, Andrew? What care should they take? Who should they tell?
But this is a really important question, and I think it's one where we're seeing the advantages of the experience we've had over the last few years. So if you believe you have COVID, or you have symptoms that suggest you might, you should get tested as speedily as possible. And we're going to talk a little bit about the testing kits that are going out to people. You should get tested as quickly as possible. But the key thing is you need to inform your renal unit, most particularly if you are a transplant patient or a dialysis patient. Because there are now treatments, and again, Liz and Richard, we're going to be covering this as we go on. There are now treatments that are offered, some of which are time dependent, depending on when you first got your symptoms. Furthermore, this has been a rapidly changing area, and it's actually not possible for everyone, all the healthcare community, to keep up with this, because it's changing so frequently. And that's why I rely very heavily on some of the experts, such as Liz, here at Imperial, and I'm sure Richard also at Oxford, to be making sure that everyone is appraised of what the treatments are, and most importantly, the process by which you can receive it, because it's slightly complicated at present. That's why the key message is, if you think you've got COVID, you get tested and you inform your unit, the transplant unit or your dialysis unit. And if you are not just transplant unit, of course, if you're immunosuppressed for any other reason, you should inform your nephrology unit. And I think that units are now much, much better at having those communication channels that we weren't as good as previously. I think what you're going to see is that this will all become part of business as usual of care as we go on into the autumn and into 2023, which I think will open up better communications for our patients if they become unwell. So test and inform. Very key message if you think you have got COVID.
Thank you, Andrew. And just one on that, I know we talked about it previously at that previous webinar, but if you're on dialysis, there's a particular message there, isn't there? Don't go in.
Yeah. You must warn,
yes.
You must warn the unit before you go in that you may or you are carrying COVID, as well, of course, as determining whether you need any treatment. So those are two messages for a dialysis clinic patient, and that's the same for the transplant. Our transplant clinic is a very busy clinic, even though we moved to virtual appointments for a number. There's still a lot of people there, and you shouldn't just roll up. You need to make sure people know in advance what your status is.
Fantastic. And then on the dialysis side of things, by telling people that you've got, letting your unit know that you've got COVID, then they will make arrangements for you to be dialysed separately and safely from the other patient.
They will not leave you high and dry. They are now well clear about how they manage this kind of issue.
Indeed. And I think it's just always worth us saying that, because those things are always probably going to be the case, aren't they? That's the situation.
I think going forward,
now.
I think it is. And we'll talk a little bit about this, I think, at the end of the latter part.
Right. So thank you very much, Andrew. Kelly, I wonder if you could just pop just a couple of slides up for people, just so to kind of bear in mind where we are at the moment. So if those of you who have got it on screen remember, I said we've only got 2 or 3 slides at the beginning and then a couple more at the end, but I just wanted to remind people of where we are. So we've talked a lot about the sorry, the one before, actually. Sorry, Kelly. We've just, so we've talked about current levels of risk. Then we've been talking about vaccinations, and now we're going to talk about new treatments. And we've allowed a good chunk of time for this, and it will be largely Liz Lightstone and Richard Haynes, who will be our experts talking about these, because we've had a lot of questions from people. So I think that's where we are now, just according to my little list of the many questions we've got there. So what we're going to be looking at is kind of an outline of what those new treatments are, how will you get them, some of the practicalities about that, and then we're going to go into preventative treatments as well, because we've had some questions about that too. But first of all, we need to go to what they are, if you've not heard too much about this or you've got questions about this. So Kelly, if you could stop sharing now, I could ask Richard to come on to join the conversation, and also in a moment it'll be Liz as well to join the conversation, but it's probably easy to have one person in the main on the screen at one time. So first of all, then, we've all been very excited by the fact that these new treatments have finally come out. They came out, I think it was started to be made available sort of mid-December, starting towards Christmas time. So I wonder if you could kick us off, Richard, with an overview of, well, what are they and how are they used before we go into any of the details? So just a rundown of what they are.
Yeah, so I mean, this is one of the good news bits, and I think why we're probably more upbeat this evening than we have been, than sometimes we've been over the last year or two. But these are treatments which have nearly all been developed since the COVID came around, so that they're treatments designed specifically for COVID, and it's fantastic that we've got these now, because they are available, and we know that we've got pretty good data to show that they work. So in broad terms, what are they? Well, Liz will be talking more about some of the details, but there are basically 2 types of treatments at the moment. One is a set of treatments called monoclonal antibody treatments, sometimes called neutralizing monoclonal antibody treatments. And what these are antibodies, which are, as we've discussed already, part of our normal immune system, which have been collected from patients who have recovered from COVID or a disease like COVID. And then they've been tested in a lab to work out which ones neutralize the virus best, which ones bind to the virus best and stop it doing its damage that it can cause. And then those individual antibodies are then produced at scale by companies in a laboratory, so they can be given in a highly purified form. And so these antibody treatments are, if you like, they're very clean, because they are fully human antibodies, so they're just like the antibodies that you would produce normally. And they only bind to the virus, and typically to the spike protein of the virus, which is the spike protein is the thing we've seen on the BBC News, the bit which pokes out the side of the virus and is the bit which binds to human cells and by which it invades the cells. So these antibodies are really good news, and they're very effective. The other type of treatments which are available are what often called antiviral treatments, which work differently. So they try and interfere with the mechanics inside the virus, if you like. So for a virus particle to get into a cell, once it gets into the cell, it then tries to replicate itself to make hundreds of copies of itself, which then come out of the cell and go off and cause mayhem. But to do that, the virus needs certain, if you like, machinery to do that, to make copies of itself, to make accurate copies of itself. And these antiviral treatments get in the way of that. In some way, they interfere with the virus creating the copies of itself, so that it can't, so those viruses can't go on and infect other cells and cause more damage. So they're the two broad types of treatment that we've got. The monoclonal antibody treatments are usually given by intravenously as a single infusion. So to get those, you'd have to go into a hospital and receive it. Whereas the antiviral treatments, most of them are tablets, although there is also an antiviral treatment that needs to be given intravenously as well. But there's options there for people who are happy to have an injection, for people who aren't. And there may be reasons why you should have one or you should have the other. I think Liz will talk more about that later. But in broad terms, they are the sorts of treatments which we've now got to help us with people who get infected.
Okay, thank you. There's quite a lot there, isn't there? So we probably will be talking about some of those a bit more, but and some of the questions, I suppose it's probably worth saying, I know we'll say it again, but perhaps we could just remind people who those treatments are for. And when we say people with kidney disease, but we're generally speaking talking about people with late stage kidney disease. And I think in the case of these antibodies, the monoclonal antibodies and the antiviral medications, they are for people at chronic kidney disease stage 4, stage 5, and people with transplants.
Yeah, so these are
correct, isn't it?
I believe that's correct, and there are a list of conditions which are defined as of which you've listed off the ones relevant for kidney patients, which mark people as slightly higher risk. If they get infected, they're at higher risk of ending up in hospital. So it's those people, not exclusively those people, that would be offered these treatments if they have a confirmed infection.
Right, okay. And I can see quite a lot of things coming up in the chat as well. Just to remind everybody who's attending, if you've got questions, please can you put them on the Q&A, because the chat is more for technical problems, and that's where Becky, Dr. Suckling, will be trying to answer them live as we go through, or we'll be lining them up to respond to as we go through the various talks this afternoon. So just to say that as well. I don't know whether this is one for Liz or you, Richard, before I forget some of these. Is there any real world experience you're aware of yet about adverse drug reactions with any of these particular treatments around hypersensitivity reactions or graph dysfunction or anything like that?
So there's certainly a lot of experience with side effects from the medication, because they've been given to reasonably large numbers of people in trials already. So we know that for people who have the antibody treatment, a very small number of people, and actually will have an infusion reaction. So they may have a sort of allergic type reaction to the infusion, but that number is really, really very low. So these they are very well tolerated. The tablet treatments, the antiviral treatments that I was talking about, just with any tablet, some people don't get on with them. They can cause some tummy upset. Some people report headaches or dizziness with them. But these aren't very, very bad side effects, and they tend to be pretty mild and settle very quickly. The antiviral treatments are just taken for 5 days. The tablet ones are just taken for 5 days. So they're not going to cause a huge burden of side effects. So overall, they seem to be pretty well tolerated.
Yeah. Okay. Right. And there's a couple of other things here. I'm getting some messages on our group as well to say a few other things about this. So first of all, then, there's a 5-day window for treatment. Does that start from the date of the PCR test confirmation, or the date I send off the PCR test? That's positive. The positive PCR test, of course, that is. I believe they started, Liz can correct me if I'm wrong, I believe they start from the day that you either develop symptoms or the day you do the test. So the date of the test or the date that you tell the doctor, because if you're going to get one of these treatments, you're going to end up having a conversation with the doctor
who's going to decide which one's best for you. And you will tell that doctor when your symptoms started or when you did the test, and that's the date on which they will start the 5-day clock.
Okay, all right. I've just been asked to remind everybody that when we went through that list, there are people who'd be eligible for these antivirals, although there's also quite a strong message from the NHS that just because you could be eligible to them, that doesn't guarantee that you will get those treatments. And we'll talk a bit more about the process of getting the treatments later on. So it's chronic kidney disease stage 4, stage 5, transplants, people on dialysis, but also there could be people with kidney diseases who are otherwise immunosuppressed. So I believe that's there as well. So I just wanted to be very clear that we have that list straight in everybody's minds, and I'm sure Liz will tell us more in a moment. Someone else asked how many of these treatments have been given out. I don't think we know how many they've been given out to kidney patients, do we? But I've seen a figure of 10,000 total treatments.
We don't know how, I don't know how many kidney patients have had them so far, but yes, I've seen the number of 10,000 treatments given out so far since this whole program began around Christmas time.
Right, okay, brilliant. There's a further question here. I think I should have got a letter about these treatments because I'm highly vulnerable, I guess in one of those classes we just talked about. So how can I get one or access the treatment if I get COVID?
So there are different ways of accessing the treatments. Hopefully most patients, and certainly if you've had a letter from the NHS telling you about the treatments, this will be the case. If you like, you're flagged on the system. So if you ever have a positive PCR test, then you will then be contacted by somebody in a local hospital, what's called a COVID medicines delivery unit, which many hospitals have had to set up. There's over 100 around the country now, who will have a discussion with you to find out whether you've got symptoms, how long you've had symptoms for, and things like that, to work out whether you should have treatment, and if you should, which one should it be. If you haven't had that letter, if you have a positive test, and from a few days' time, from the 10th, that can include a positive lateral flow test, as long as you've logged that lateral flow test on the NHS website, then if you don't get the phone call, it's still possible to get these treatments, and you would need to make contact either with the 111 service and explain your situation, or with your GP, or with your kidney doctor, and any of those would hopefully be able to refer you in. Now, I understand this works, unfortunately, this works slightly differently around the country as to how the system would work. So you may wish to start with, it may be that you end up being told to call 111 to get that referral working for you if your GP or your kidney doctor can't do it for you themselves.
Okay, and what we'll do is we'll go back through that again with Liz in a moment, because there's some changes there and some new messaging there as well. Right, so for now, thank you, Richard. The new treatments are there, a little bit about how to access them. And then Liz, I think it's time to bring you back onto the screen as well, and to start to explore a bit more. So Richard's explained that those treatments are available. He's given us a bit about, the sort of any reactions and so forth, and a little bit more about the 5-day window. So I think it's probably over to you, because I know you've been very well involved, just as Richard has, with advising on the rollout of these. So first of all, I mean, we've heard about these medications. We've also heard today that there are actually some more medications that would be offerable through these COVID medicines delivery unit. So the first question, I think, is how will the doctors decide if I am COVID positive and my test is sent through to the system, and so the system knows about me? How will the system then decide, or how can I choose which of those medications I get and which are the right ones for me? And I'm speaking right now as somebody either with kidney disease or someone with a transplant. You can put yourself in different people's shoes if that helps.
Yeah, so actually in some ways it's got easier, and I think there's some really good news out there, because the choice we have until Thursday is between two drugs, something called sotrovimab, which is the monoclonal antibody that Richard was talking about. We had Ronapreve, some of you may have heard about, doesn't work against Omicron, so we've moved on to sotrovimab, or an oral drug called molnupiravir. And there's a big difference in efficacy. So molnupiravir reduced your chances of hospitalization in the trials, that this isn't real world data, this was the trials, by 30%, and sotrovimab by about 85%. So you can see there's a difference there. We were pushing for our patients that we knew had low antibodies to have sotrovimab, but that does mean you have to go up to a unit. We were doing it on the dialysis unit for our dialysis patients to have an infusion. So it's not minor. But actually on Thursday, it all changes. So we then have a choice of 3 drugs. Molnupiravir is essentially gone. And we have a choice of a drug called Paxlovid, which is actually 2 drugs, and you have to take 2 different lots of tablets. Or intravenous remdesivir, which has been being given in hospital for a long time for COVID, to treat COVID, which is an antiviral, for 3 days, or sotrovimab. And they are all really effective. So Paxlovid, I think, reduces the risk of hospitalization by 89%, 3 days of remdesivir intravenously by about 87%, and I think sotrovimab by 85%. So there's no difference. So you've suddenly got a choice of 3 really good treatments. That's really useful because most kidney patients are not going to be able to have Paxlovid. It's a really difficult drug for drug interactions. And actually the recommendation from the Chief Medical Officer and the NHS England is if you have a solid organ transplant, you get sotrovimab. So it's become less of a question, actually. That's what you will be recommended, because Paxlovid interacts with tacrolimus, so it becomes almost a no-no. You could probably stop your tacrolimus, measure your levels, but how do you measure your levels when you're stuck isolating at home? So it's too complicated. So transplant patients are all going to be offered sotrovimab, and that's certainly what we're going to do within hospital patients who have incidental COVID. You know, they've come in with a broken leg and they're found to have COVID. So that's one easy win. There's other drugs that a lot of patients, particularly with CKD 4 and 5, are on that mean they cannot have Paxlovid. So statins are a big one that are a no-no, and clopidogrel, which a lot of people are on for heart problems, is a no-no. So if that's the case, again, they can't have Paxlovid. And if your function is less than 30 mils per minute, if your GFR is less than 30 mils per minute, you can't have remdesivir either. So you'll get sotrovimab. So this won't be up to you. The CMDUs will have a very clear, quite complicated chart to check. So Paxlovid is considered first line for everyone, but then you have to check all the drugs. And if there's an interaction, then you think about remdesivir. And if your GFR is too low, you go to sotrovimab. So that will be largely how it's decided. If you are fine and not on any drugs that interact, then it's fine to have Paxlovid. And that will be offered, say, to the patients who've been on rituximab for autoimmune kidney disease, the young patients who aren't likely to be on the other drugs, they're going to get Paxlovid, I think. So actually, the CMDUs, when they opened, were asking people what they wanted. And a lot of people chose molnupiravir because it was more convenient and they could have it at home, blah, blah, blah. Actually, I think the choice will essentially be gone, because I think your condition will define which one is most appropriate for you. And sotrovimab is 1 intravenous injection. Remdesivir is daily for 3 days, a bit of a faff. And Paxlovid are tablets that are quite complicated that you take, I think, for 5 days. But there's different dosing depending if your GFR is above or below 60 mils per minute. But the CMDUs, I saw somebody posed a question, will the CMDUs know? Oh, the CMDUs know. And this has all been highlighted, all these drug interactions.
Great. And I think that's important, isn't it? I mean, people on the webinar are probably very likely to want to know that. But I think the message is that generally speaking, it's not suitable for everybody, but it's not a blanket for nobody.
No, but there is proper choice now of really effective drugs if you're positive, but they're all time limited. So the message that Richard said about making, and Andrew said, get tested, and now you can do it on a lateral flow test and report it, is so important, because you don't want to say, the computer will say no if you're out of time, or if you don't have symptoms. So the message is you have symptoms. Everyone has a little bit of a symptom, and don't quote me, and I realize there's a lot of people on this webinar, but you can have a headache, or you can have an ache or a pain. If you say you're completely fine and have no symptoms, you will not be offered this treatment. And I actually think it's a huge advantage to be offered the treatment. So yeah, have a cough or a headache or a sore throat.
So just to repeat that again though. So if you test positive for COVID, and and I know there's lots of questions about the lateral flow test and the PCR test, and we'll re-say those again in a moment. Nevertheless, you must get tested, and you must report that. Either you can ring 119 or you can go online to report that. And I know it's slightly different in each country, but it's fundamentally that same: report it, test, report it. You will then be contacted and offered, in the main, for people with transplants, Sotrovimab. You may be offered Paxlovid if you're in certain conditions, and some people on dialysis, they're likely to be offered Sotrovimab as well.
Yeah, they might be, but they could also have remdesivir, because if you're on dialysis, remdesivir is fine as well. So they may be offered, the people on dialysis, depending what other drugs they're on, may have a choice of all three. We've tended to suggest that patients we know don't have antibodies should have the antibody, because it's giving you what we call passive immunity. It's protecting you just as the virus would protect someone whose immune system worked properly. But if you're a straightforward dialysis patient, you're not in immunosuppression, then you can have remdesivir. You're very likely to be on a statin, so you may not be able to have Paxlovid. But they can make a decision to think about stopping the statin, but I think most people will be offered remdesivir or Sotrovimab.
Fabulous. Thank you ever so much. I mean, there's some great comments there about people making this clear. And if your symptoms are mild, or you don't have any impact at all from COVID, you won't get those treatments. But if
you'll get them if they're mild. It's only you will not get if they will ring you up and ask you how you are. They will want to know if you're pregnant, if you're a woman, because you can't have. I think you certainly couldn't have molnupiravir, and you probably can't have Paxlovid if you're pregnant, and they will ask you if you've got any symptoms, and a lot of people minimize their symptoms, but you have symptoms. If you have absolutely none, that's fine, and you may choose not to, but they will not give you treatment if you say I have no symptoms. But if you say I've got a headache and I feel a bit under par, that's a symptom. Their list of symptoms is very long and includes almost anything you could think of.
Okay. Thank you. That's really helpful. Hopefully everybody has heard what that means and what that might mean to you. Hopefully you won't get COVID, of course, but nevertheless, these are the things that are in place at the moment. What about getting the treatments again if you get COVID again?
That's a really good question, and I don't think we've entirely come to grips with it. But I think if you get it again, I don't know about getting Sotrovimab again. So certainly not within 28 days, because you will have the antibody on board. We can definitely give remdesivir again, because actually, if you've had proper COVID and you've needed treatment for COVID as an inpatient and you come back in, you can get it again, even if you're not immunosuppressed. So I suspect we can give remdesivir again, and I truly don't know about Paxlovid, but I can't see why you wouldn't. I think very unlikely you're going to get, if you've had Delta, you can get Omicron. We don't yet have data on repeated Omicron, and it may be that next year you get it again, and then I can't see why you wouldn't be able to be retreated, but we haven't really got there yet.
Okay. All right, well, thank you. That's a very, very interesting answer to that one. So just to run through the things that Richard and Liz just said. So this is from the 10th of February. These further new treatments will be added to the arsenal, if you like, of protection for people like us, people with kidney disease, people with transplants, people on dialysis, and so forth. And also from that date, you will be able to use a lateral flow test or a PCR test to confirm your COVID infection. And so I'm just going to read this to make sure I get it right. So if you're in that highest risk group, you can from the 10th of February use a lateral flow test, although PCR is still preferred. But that means if you don't have a PCR test, this is already in place in Wales. And in Scotland, you can in some circumstances, but in Northern Ireland, you still need a confirmatory PCR test. And those are the details. We'll make sure those details are on the COVID information on the website. And the other thing just to note is that prescription charges, even in England, prescription charges have been waived for these drugs. So that's a good one to know as well. Okay. So I know there's a lot of questions we've had about the practicalities on here. Hopefully that announcement about the lateral flow test will really help people. And I know people are quite worried about what to do if they don't hear from the the COVID medicines delivery unit 24 hours after the PCR test. So the advice, as Richard just said, and Richard, maybe you could just pop onto the screen just for a moment, please, that if they don't hear, they should contact the consultant, call 111, or of course call your GP. So I just want to, I think you're nodding on that, so that's fine. But then we had a further few questions that have come through about some of these other practicalities. And we have heard again from the NHS today that they know that the communication perhaps with GPs wasn't as widespread as it could have been just before Christmas. That's all being renewed this week very, very actively. So we trust that that will improve, and I'm sure you'll all let us know if that's not happening. But if someone's travelling away from home within the UK, will they still be able to get the treatments? I think the answer to that is yes, isn't it, Richard? But please, can you just give us reassurance on that?
I can't see a reason why it wouldn't work. It may need an extra couple of phone calls. But yes, the answer is yes, you should still be able to connect it. I can see Liz has just popped her hand up.
But take your test with you if you're travelling. Liz, want to join us?
Yeah, you might have, sometimes the computer says, oh, you're not in our, your GP is somewhere miles away, and they get a bit stroppy. But I think that's where you get your unit involved if there's a problem. But there is no reason why any CMD you can't give it, but they just occasionally, because remember, the people asking you are not medical, they're working to a script. So sometimes you might have to push a bit if you're away, but there's no reason why on earth you shouldn't get it. And we've certainly sorted it for people.
Great. Okay, if you could both just stay on the screen for a moment then as well. I think we've covered the how do I get a replacement test. So again, you can call up for one on 119. That should improve things, or you can ask your consultant. But you should be receiving letters from your consultant soon if you haven't received them already. But you can use a lateral flow test anyway now, which should make that a little bit less stressful while you wait for a PCR test. And then there was another question about which I don't know which of you can answer this. If I'm away, I don't have a car, my nearest hospital is miles away, how do I get my infusion? Will I get transport to help me?
They're supposed to provide transport. I have to say, I've heard worryingly that RCMDU hasn't necessarily done that, but they are supposed to provide transport for you. So they should. And I imagine that outside London, they'll be better set up because they're more used to the distances. In London, they think everyone can just nip round and get there. But I know. I mean, my understanding is they're supposed to provide transport to get you there. But okay. I appreciate that might not always happen.
Richard, have you got anything to add to that?
Nothing, I'm afraid. No extra information.
Okay, and I had seen that come through in some of the guidance myself as well. Again, I'm sure people will let us know if that's not the case. Okay.
Liz, sorry, I volunteer for our local CMTU, so I've had some experience in doing this sort of work on the other end. And initially we weren't offering transport because there were ways of delivering the medication, but since the regulations have changed, offering different medications, we are offering transport. So things change as what's on offer changes. Because we were able to courier out some stuff, so you weren't given infusions if you couldn't get to the CMTU, if that's any help.
That's brilliant. No, that's fantastic. That's why we're all got people on here from different parts of the country.
Yeah,
people can see that the guidance
it should change. It should change. It just changes all the time. It's really hard to keep up, even if you're working there.
If you're working on it as we do at the moment. Okay, thank you. So I think there's one further area that people have been asking us a lot about, and it's about preventative treatment. So we've heard quite a lot already about the new treatments that are coming on, about the tests, that 5 days, don't forget that 5 days as well. And we all very much welcome the provision of these treatments. However, there's a fairly obvious question that all of this begs, and it's come up quite a lot in the chat as well as through the questions we got. What do we think about either, well, the question is antivirals, but I'm going to say antivirals and antibodies being prescribed to people who are in those highest risk groups, which could be immunosuppressed, ahead of symptoms. And another question here is about why aren't monoclonal antibodies being given as prophylactic, as preventative treatments, which is, I believe, being done already in the US and I think in France as well, actually. What do we think? Game changer possible? Liz, what's your views on that?
Sorry, I completely zoned out, which was very bad. I was looking at the chat. You have to ask me again.
Right. antivirals, antibodies as preventative
Ah,
treatments.
yeah, no, favorite
Come on,
topic. So
number one
sorry.
topic from today.
Yes, so this is the whole question of, at the moment, the only early treatment you get is once you're positive, and then if you're clinically vulnerable, you are offered these treatments. There is an argument, particularly with everything opening up now. So in some ways, people were much more protected. When everyone had to wear masks and everyone had to be well behaved, people felt much more comfortable when they were out and about. But now we're going to see a complete relaxing of restrictions, and by the middle of March, I think March 21st, more or less everything's gone, and I think people feel worried. So the question is, are there treatments we can give to people that will protect them long term before they even get their COVID? And there are treatments. Sotrovimab actually has been used for what's called pre-exposure prophylaxis, but there's a drug from AstraZeneca called Evershield. I think everyone thinks it's called Evershield, but it's not. It's called Evershield or something, that has been licensed in America by the FDA, the Federal Drug Administration, whatever, for use as pre-exposure prophylaxis. That is not yet approved here. It's going through the MHRA process and is likely to be. There are, however, studies going on. So there's the Protect 5 study, which has been looking at an inhaled treatment called niclosamide, and then there's got another inhaled treatment, the name of which I can't remember, as pre-exposure prophylaxis, the idea that you're stopping virus getting in by inhaling this stuff. And they are about to open, I don't think they've opened yet, with sotrovimab, the antibody that you can get as treatment, as pre-exposure prophylaxis. And you would be randomized to either get the drug or not. So there's a lot of interest in this. There's no routine treatment with pre-exposure prophylaxis. And the truth is that with Omicron being less severe, it may be that it's not appropriate to give everybody an antibody, because you're always looking at risk benefit. When there's really a lot of it about and a lot of people getting infected, then the risk, or when you've got it, that's, you know, the risk of the infusion reactions, all that is balanced by the risk of the disease. But when you haven't even got it, there is a risk to having any of these treatments. So you need to think, is that a justified risk? So doing a clinical trial is definitely the way forward. There's a trial that Richard probably knows more about that's about to start or being developed from Oxford, using the AZ drug as pre-exposure prophylaxis. And we're talking to them about using the MELODY study as a stepping stone to doing a real world effectiveness study in thinking about giving the AZ drug to people that we detect are negative in MELODY. But I mean, that is not on the cards yet, but that's what we'd quite like to do. So there's definitely stuff around the corner, which I think is even greater cause for optimism, that there will be protection. And you'll know that in other diseases, we use pre-exposure prophylaxis, notably in the viral infection HIV. So it's out there as a possibility. And the reason the drugs are possible is they give very long-acting protection over months. And the AZ drug might even be longer than a year. So I think there is interest, but they're not out there available yet.
Thank you. That's enormously helpful, because there's so many questions, and a lot of people we've heard from, and you'll see it on the chat there as well, is about how people are feeling anxious about what happens next. And certainly at the charities, and certainly we've been working to ask some of those questions about you know, what happens next, where do we go next. I just wanted to share with you, it may be the study that you were mentioning, so an answer to a parliamentary question that came up last week. This is a statement from the government, and it said that immunocompromised individuals are a priority cohort for research into therapeutic and prophylaxis treatments. That means protection in advance, such as monoclonal antibody therapies and repurposed compounds. The rapid COVID-19, that's called rapid COVID-19, collaboration actively reviews all promising compounds. To date, the evidence has most strongly supported treatment use, but the evidence around prophylactic use will continue to be actively reviewed. So it's slightly hopeful, I would say that.
Yes, I think it might have to go through the pain of a clinical trial, not in any way dissing clinical trials, but it takes longer. And the problem is, the good news is the Omicron wave is declining. So there is a big drop in infections. Of course, that means it takes much longer to show a benefit of an intervention, because you've got fewer people getting infections overall. So to show that even fewer get them takes a longer time. But I don't think we can be unhappy that the rate of infections is going down.
No, indeed, and that's a very fair point. Richard, is there anything you wanted to add to that? Because I'm then going to come on to Andrew as we start to move towards the summary part of this webinar about keeping ourselves safe.
No,
yeah.
No, nothing I'd add to that. Thank you.
Okay, fantastic. Right, so Andrew, could I ask you to, thank you so much, both of you. Thank you, Liz. Andrew, could I ask you to come back onto the screen now, because there's kind of a range of questions and things you've heard it sort of reported as we go through here as well. Kind of levels of anxiety, and I know, people, we have all been very anxious throughout this period of time. And you said at the beginning that some of these things are starting to change, and we'll share a few ideas and some resources in a bit. But here's a question. Will the government still work to get infection levels down to a safer level for all of us?
Well, of course, Fiona, I really can't answer a question about what I think the government will and won't do, but I can make a reasonable guess that unless something dramatic happens, I think the days of nationally determined actions to minimize spread of COVID are past us. And I think that once we reach March the 21st, as you said, when many of the restrictions are eased, unless something dramatic changes, which we don't predict, that is it. And it's really about individual choices in relation to how they protect themselves against COVID. Does that answer the question, Fiona? I think it's probably the best we can do.
Yeah, I mean, it's kind of a nuanced answer, isn't it? And we've talked about this, before. We've still had lots of questions around that, about how people, it's difficult to assess your own risk because different people are at different stages. If you just had a transplant, for example, you'll be new to immunosuppression. People will have always been advised to keep themselves to themselves. I mean, that's not new guidance at all, is it? That's something that's been around.
No, that's
I remember that when I had my own transplant. Those are the things that are around there. But a lot of people have been shielding for the whole pandemic. We talked about the new treatments are there. We talked about the possibility, which seems very, very hopeful to us, about pre-exposure treatments as well. We talked about the fact that some of the infection levels are going down. We talked about vaccination, but there's also how people can assess their own risks as well. And so, I mean, for people who've been shielding the whole pandemic, there is a point at which to consider where we go next and how we try to get on with life. And the protections, I mean, we tend to call them protections because they're protections for us rather than restrictions, as I know sometimes it gets reported in the media. Some people haven't been in touch with anybody at all, more or less, over this whole time from hospital appointments. Have you got any kind of advice about how people can perhaps kind of take a sensible approach to that and a sort of mediated approach?
Yes, and I said at the beginning, I completely understand that there is still anxiety there. There is also uncertainty, and I know that people would like to know, my risk is on a level of 1 to 10, number 8, and that means I should be doing A, B, C, D, and E. Sometimes it's not so easy to determine that. And I would urge you all, if you are still considering yourself at that more advanced risk, more significant risk, to have a conversation with your treating team, your nurse on the dialysis unit or your treating consultant, to talk about what your actual risk is. There's no urgency about doing this, but I think if you're fully vaccinated, your risk as we emerge and the numbers from Omicron go down is going to significantly decrease, even if you are immunosuppressed. What you then need to do is, once you have a handle on where your risk sits, you need to think, what are the behaviors that we have used over the last 2 years that actually I would like to continue to use? And you may decide that you will wear a mask in public places. You may decide that you may actually avoid using the London Underground at peak times. But you may decide that you are now able to come out and meet people in a way you weren't before, because you've got that added understanding of your risk and added confidence in the treatments that are available. Because as I've said, COVID will become part of our seasonal viral infections. And we really do need to try and encourage people to return to some form of normality, but actually pick up the good practices from COVID that will protect you if you are immunosuppressed.
So can we just remind ourselves what those, those good practices are? Here's a clue.
Yeah, so hands, face and space. So that was the original one, as you know, that was on all of the press conferences at the start. Yeah, so frequent hand washing will protect you and will protect me as a person from getting a cold. If you're frequently washing and cleaning your hands, you are less likely to get a viral infection that is spread by airborne or by touch. So wash your hands frequently. That's something we should all be doing. Be careful about touching your face, using a mask in specific situations that you feel comfortable with. And I would remind you that in the Far East, I've been to China a number of times, and I could never understand the fact that people wore masks. And you do actually see that in people from the Far East in London. They wear it to protect other people and to protect themselves. So you may decide in circumstances to use masks. And space. This is a very personal one, because clearly if you want to go to a football match on a Saturday afternoon, it's going to be difficult for you to maintain space. But you should be using that space rule where you feel it's in your interests and that it's practical. So hands, face, space, mask are just some of the things that we'll take from this whole COVID pandemic and we'll build into our normal way of life.
So would you think I was mad if I carried on? Well, I doubt you'll say that on a webinar, but nevertheless, if I carry on wearing a mask, if I go on a train, something like that, I feel that would make me feel more comfortable.
If that makes you feel more comfortable, I certainly, if I was sitting opposite you on the train, would not blink an eyelid. And I think that's what people do. I also think there's a change now in terms of people sort of going around with infections. And I hope that continues. In the old days, people used to come into work with streaming colds, or, I've got a flu, but I've struggled in. I think people will be less and less likely to do that. And when you invite people over for meals, I think if they phone you and tell you, actually, I've got a cold or I'm not feeling well, you'll say, well, thank you very much for telling me. See you next week or something. Right. It's a different way that we will be behaving now. And I think that's all part of it.
Right. Well, I'm glad you've mentioned employment, because we've had quite a lot of questions coming up about employment and what can my employer do, all of that kind of thing. So I think it's probably worth us mentioning, first of all, the Safe at Work initiative, and then maybe you could comment on that, and we'll see if any other members of the panel want to comment on any of this. So at the moment, we've had it confirmed that people who are in the immune suppressed category, so that Department of Health and Social Care has confirmed that they are still in a situation where they can, be supported to work from home. So the advice is work from home if you can. Please discuss with your employers, and an encouragement to employers. I know not everybody can work from home, but everybody's entitled surely to a risk assessment because of their particular situation. And so what we've done, and all the kidney charities together have also signed up to this initiative, which is a letter for people to take to their employers for kind of a risk-based discussion, and we'll be sharing that later on, but very soon actually, because we're nearly at the end of the webinar. And I wonder if you had any comments about that, or employment for. Well,
Fiona, I think the answer to this question is exactly the same as the answer to this question as it was in, I think, most of the previous webinars. That is that if you are clinically extremely vulnerable, if you're immunosuppressed, you are entitled to a risk assessment. I'm pleased to hear that you have a letter now to support you. I would always again reiterate what I've said in the previous webinars, that is that you should also ensure that your treating physicians or nurses are also supporting you, so in having those conversations with your employer. And as far as possible, they should be able to look at your work and think, well, how can we make this as safe as possible for you. That's what they are required to do. And your consultants should be backing you on this, and I'm sure absolutely that they will. So this really is unchanged about your right to a risk assessment.
And I know that lots of people worry about that. We can see some of the comments about, you know, how you assess your own risk as well, where there's less, you know, national support out there. So I would go back to people about the wearing the mask, talking to your employers, and keeping an eye on our websites as well, because we do put the very latest updates up there about what's happening at the different levels of all of that. And that is a struggle. I think it's worth us acknowledging that will continue to be difficult for everybody, because we cannot possibly spend 2 years, and I say we because I'm in that situation as well, as you know, of somebody who is shielding, and expect to jump straight from here to here. And I think we will need a lot of time to cope with that. And that's sort of the patience that we'll be asking for from our consultants and from everybody that looks after us as well.
Fiona, can I just say one other very important point, which again is something we've mentioned before and must be reiterated. When you are making decisions about your health and the way you're going to behave, please use accredited information. Be very careful about what you read on the internet. You know, a new variant has come from, I don't know, Angola and is going to devastate the community. Please make sure that you get your information from the right sources, and the Kidney Care UK website and the UK Kidney Association website are just the places to go, because there is still so much information out there that is really not properly checked, and is quite alarmist. So I would just want to reiterate that.
No, thank you very much for that. And if there's any other members of the panel that want to comment on that, can you just let me know? Otherwise I'm going to ask Kelly just to put up the last couple of slides that will just summarize some of the resources for ourselves and our partner charities. And so, Kelly, could you do that while any other members of the panel want to comment? And I know that I can see there's zillions of questions still going on, and I can see we've had 88 questions answered live, and we've still got a number of them on there as well. So Andrew's just giving you some discussion. Thank you, Andrew, about keeping safe in general. There's the link to the Safe at Work Coalition and that letter for employees. If you've not seen that, that'll be written up in this webinar as well. Could we just go on to the next slide, please, just as a couple of further reminders. Kelly, thank you. That's okay with you, it's going to work. Right, so some resources from us and from our partner charities coming up. So as we said before, and I know that's frustrating, but we can't answer your personal questions on the webinar directly, although I'm sure that Dr. Suckling has done a fantastic job of doing that. So there's a Kidney Care UK website on there, and there's sort of advocacy, emotional and financial support through that. And the next slide, please, which is for our colleague partner charities, so the PKD charity, NKF, Kidney Research UK, Kidney Wales, and the UK Kidney Association. So those are all up there as well. I wonder if we could just go on to the next slide, please, about things I can do for myself. And then I invite Becky, because I can see that you've come up there, so you might want to say something. Keep an eye on our websites. Remember the hand, face, space. Keep your PCR test or your lateral flow test in a safe place. Get yourself vaccinated and your family members to do so. If you're immunosuppressed, you'll be able to, that remains an evergreen availability. We talked about a number of research studies on here. I've written write to your MP because I know some people have been doing that and some have had some less helpful responses on that. Talk to your employer. Becky, anyone else, did you want to make any other comments before I close it down and thank all of our panelists?
Just a couple of things. There was some concern about the reliability of lateral flows, if that was going to be used as access to other treatments. I just didn't know if the panel had anything to say about that. Otherwise, I think the biggest concern is individual risk and the difficulty in assessing individual risk. For example, if you're a transplanted patient who doesn't have any antibodies, what is your individual risk? And I think that, I mean, for me, that's a challenge for me to answer in the Q&A, but I don't know if anyone has any comments.
So panel, any comments you'd like before we close
Yeah,
it
so
down?
the lateral flows are probably a very, very good marker of having an active infection, but they might become positive slightly after your symptoms develop. So if in doubt, do a PCR, which will come back positive. And then the lateral flows are a good measure that you've still got infectious virus as you go on. So they are good. They're not perfect. None of the tests are perfect, but they are good. And if you're worried, just do a PCR to corroborate or whatever if the lateral flow is negative. But if it's negative one day, it may be positive the next day. And lots of people report seeing a faint line and then a really positive line. So I think they're pretty reliable. I don't know what to say about individual risk. It's really difficult. And I think people have to decide for themselves. You know, people with young kids, the kids keep coming home with different infections. And I've just heard from a patient of mine who we know has no antibodies, and he's been going through a cycle with his children getting infection, almost certainly Delta and now Omicron, and he isolates when they come home infected. I think it's really hard.
It is really hard. And I think the message for us to take away here is that your medical teams, there are so many people who've been working so hard throughout this to be as honest, as transparent, as evidence-based as possible to do the best that can be done on this, and that people, and I think there's a huge, again, set of gratitude to all of those people to do that, to continue, and the fact they've continued to do that throughout this. We do have a small level, we do have a level of uncertainty. It is getting better. And we now have those new treatments and possible other new plans that will help us as we go along. And we're all going to continue to work together to address those things. So feel free to keep sending us all of your questions as we go through. And finally, I'd just like to thank, and I'm sure you'll agree with me, to thank our panelists. So Rebecca Suckling, Liz Lightstone, Andrew Frankel, Richard Haynes, thank you so much for answering all of those many, many questions that have come through. And thank you to our audience as well, and for the questions you've asked. I hope this has been a step as we move along to a different situation. And before we go, there is that final request to you. It'll be sent out to you anyway afterwards. But if you've got feedback, thanks for your lovely comments just there. But if you've got any further feedback, there's a short survey that will take you, it won't take you 5 minutes, it'll take you a couple of minutes to do. And on that note, thank you everybody. Thank you for all of your time. Thank you to all of our partner charities, all listed down the bottom there as well. And here's hoping to better times. Thanks everybody, and good night.